This is the CPE testing format for static cardiology. Rules of static cardiology. The rhythm doesn't change throughout your treatment. There are a total of 12 points available, 3 for each rhythm. 1 point is for interpreting the rhythm correctly. The other 2 depend on how you verbalize your handling of the scenario. If you do not get the rhythm right, you do not get any of the points for the scenario. You will be presented with a rhythm and a brief description of the patient. Read the description, then identify the rhythm before continuing to your treatment plan algorithm. Don't waste time in beginning the next rhythm. You will have a total of 8 minutes to complete the whole station, which includes 4 rhythm strips. So to begin, BSI scene safety for all my patients, I'm going to read scenario number 1. You are called to a 76-year-old male who was found unresponsive on the floor. His family states he was having chest pain all day and then slumped over. The family tells you the patient had a myocardial infarction 3 years ago but is otherwise healthy. Upon your arrival, the patient has no pulse and is not breathing. Well, the patient is in pulseless VTAC. I'm going to start my Clyde treatment, CPR at 30 to 2, put leads on the patient, start an IV, check a blood sugar, and intubate. After 2 minutes of CPR, we'll do a pulse check, rhythm check, and defibrillate at 200 joules. We'll do this every 5 cycles or 2 minutes of CPR. We're going to give 1 milligram of 1 to 10,000 epinephrine IV and repeat that every 3 to 5 minutes. We're also going to give 300 milligrams of amiodarone IV and follow that 3 to 5 minutes later with 150 milligrams of amiodarone. Next, scenario number 2. You're called to the scene for an 88-year-old female who is complaining of weakness and dizziness. She states that she's been unable to get out of bed today or even sit up because she feels so weak. The patient states she has a history of a myocardial infarction 10 years ago. She takes aspirin every day, but no other medications. She's also experiencing chest pressure and some difficulty breathing. Upon your examination, you find that her BP is 60 over palp, heart rate is 29 carotid, respiratory rate is 12, skin signs are pale, cool, and diaphoretic. Well, this patient's in a 3rd-degree heart block. I'm going to start my vomit 12 lead, which is vitals, blood pressure, heart rate, respiratory rate, SpO2, oxygen, put her on the monitor, start an IV, and eventually transport and do a 12 lead. We're going to consider giving this patient 0.5 milligrams of atropine IV, but since she's unstable and atropine's unlikely to work on a 3rd-degree heart block, we can go straight to pacing. We'll set the rate at 70 BPM and increase the milliamps until we have electrical and mechanical capture. We can give dopamine IV piggyback, 2 to 20 micrograms per kilogram per minute, or epi, 2 to 10 micrograms per minute IV piggyback for her blood pressure. We'll continue to reassess and reevaluate en route. Next. Number 3. You're called to the scene for a 38-year-old female who is experiencing shortness of breath. Upon arrival, you find a female sitting on the couch in a residence. She appears to be breathing at 40 times per minute with no accessory muscle use or tripoding. She states that she just had a fight with her boyfriend and that she began to have a hard time breathing. You notice that your patient has spasms in her hands, and she states she has tingling and numbness in her hands, feet, and lips. Her vital signs are BP 128 over 68, heart rate of 90, strong and regular, respiratory rate 40 and shallow, and her skin signs are warm, moist, and pale. So this patient's in normal sinus rhythm. We're going to do our vomit 12 lead treatment, vitals, blood pressure, heart rate, respiratory rate, SpO2, assess the need for oxygen, monitor, IV, transport, and 12 lead. For this one, it's just general supportive care and transport. Next, scenario number 4. You're called to the scene for a 67-year-old male with chest pain. Upon arrival, you find a male sitting on a sofa in his living room. The patient states that he began experiencing chest pain about 45 minutes ago while watching TV. He states that the pain is an 8 on a scale of 1 to 10 and that it's crushing in nature. The patient states that the pain centers around his sternum and radiates to his right and left shoulder. He states that he is a diabetic and takes insulin, furosemide, and digoxin. He says that he is allergic to sulfa drugs and nothing is making the pain better. His vital signs are as follows: BP 160 over 92, heart rate 110 and irregular, respiratory rate 24 and slightly labored, skin signs are pale, cool, and diaphoretic. Well, this patient's in AFib. And we're going to do our vomit 12 lead treatment, vitals, blood pressure, heart rate, respiratory rate, SpO2, oxygen. Put them on the monitor, start an IV, eventually transport and do a 12 lead. We're going to ask about allergies, any recent history of GI bleeds, any SED use within the last 24 to 48 hours. We're going to give them 162 to 324 milligrams of aspirin PO and 0.4 milligrams of nitro sublingual. Repeat that every 5 minutes, giving him up to 3 doses, so long as his systolic blood pressure is about 90 and his pain is unrelieved. We'll also give 2 to 10 milligrams of morphine for his chest pain, and we'll continue to reassess and reevaluate en route.